So this is a video that I've been wanting to do for quite some time concerning lung sounds. It's a video that has been in the works for a very long time, and I thought, oh well, let me just do it right now. Grab a piece of paper, in this case, and your headsets, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at lung sounds. I will leave this video tagged in all the playlists on my channel such that you should be able to find this video wherever you go, because I feel it's a very important video to actually look at, very important video to know. I did a previous video on heart sounds. If you don't know where that is, I'll leave it tagged at the end of this video. I'll also leave a card right here that you can click on to go and watch that video, especially on heart sounds. So today we'll look at lung sounds. So if you don't have your headsets on right now, you may not be able to appreciate these audios that I'm going to be playing for you. So please get your headsets, pause the video right now, get your headsets, plug them in so that you can get the best of this particular video. So remember, in every examination, there is a technique that we follow, and this technique is known as IPPA. You have inspection, you have palpation, you have percussion, and your auscultation. Auscultation is what we're going to be focusing on in this particular video, because this is where we turn to listen for abnormal and normal sounds in the lungs, both with our ears and with the help of a stethoscope. So these abnormal lung sounds, or these lung sounds, are going to be often heard during auscultation of the patient's lung. You should be able to distinguish between these different lung sounds, the normal from abnormal, because these are going to help you pick up the underlying pathology. And remember, whatever you pick up from your person's chest, you must always tie that to your clinical history for it to make sense. If you just get an isolated random lung sound, it may not be quite specific without any clinical context. So it's very important to have clinical context. So you're describing your lung sounds. I want you to think of these 6 things and ask yourself these 6 things that are going to help you distinguish different types of lung sounds. Number 1, ask yourself, where is this happening? Which phase of respiration? Remember that respiration is both during inspiration and expiration. Is this sound heard louder during inspiration? Is it heard louder during expiration? Is it heard loud during both inspiration and expiration? I will tell you and show you the different sounds and which ones are louder during inspiration, which ones are louder during expirations, which are the ones which are continuous. Both inspiration and expiration have the same loudness. The second thing you ask yourself, is this a continuous or a discontinuous or a non-continuous sound? If it's continuous, meaning that the sound doesn't have any breaks in it, it's constantly just like that. If it is non-continuous, it has a series of short sounds that can be broken up. The third thing that you're going to ask yourself is, what's the pitch of the sound? Is this a low-pitched sound? Is it a medium or high-pitched sound? Low-pitched meaning less than 200 hertz, high-pitched greater than 400 hertz. I'll also play for you a few sounds that are low-pitched, those that are high-pitched. That's why I said get your headsets so that you can distinguish between these. Is it a musical or non-musical sound? Remember, musical is another word that we can use for continuous sounds. There are some sounds that sound musical. I'll play them to you. And is it a dry or wet? This is usually specific for a type of sound which are known as crepitations or crackles or rails. For example, you can describe them as dry, you can describe them as wet. And you ask yourself, what's the intensity of the sound? Is it a soft? Is it a medium? Is it a loud? Is it a very loud sound? So what exactly causes these lung sounds? Remember that most of these sounds that are abnormal in the lungs could be as a result of obstruction. So maybe it could be mucus that's blocking the airway. It could be that the airway is inflamed and there's edema of the airway. It could be a foreign body that has been aspirated. Sometimes it could be due to inflammation of the pleura. So all the conditions that you can think of are inclusive of some of these things, including respiratory infections like bronchitis or croup, very common in children, because they have a smaller airway than adults. You can have pneumonias, asthma, chronic obstructive pulmonary disease, cystic fibrosis, allergies, anaphylaxis, tumors, foreign body objects. You may even have pulmonary edema, interstitial lung disease, heart failure, even pulmonary embolism. This is just a few causes that are going to give you abnormal lung sounds. So generally, when you think of these lung sounds, you can group them into three main categories, which we shall discuss. First, I'll start off by discussing what the normal sounds like, so that you have an idea what normal lung sounds are actually supposed to sound like, such that when I play you the clips for the abnormal lung sounds, then it'll be easier for you to pick them up. Or they could be adventitious sounds or abnormal sounds, or it could be in the background of a technique that we often use during examination, which is known as vocal resonance, which I will discuss towards the end of this lecture. So we'll begin with the normal breath sounds. So remember that these are going to be heard over the entire chest using your stethoscope, rather than what you're hearing with the breathing of the patient's mouth. So the normal breath sounds could either be tracheal, they could be bronchial, they could be versicular, they could be bronchovesicular. What's the difference? So remember that before we actually get into these different sounds, you can differentiate them based on where you're actually auscultating them. For example, the bronchial breath sounds, you can hear them at the right apex of the lung. But if you hear bronchial breath sounds at the base of the lungs, it means they are pathological. So these lung sounds, when they are heard in places where they're not supposed to be heard, that's one thing that's going to give you a hint that this is abnormal. So generally, the four different sounds, that's your tracheal, bronchial, bronchovesicular, and versicular breath sounds, are going to be heard best depending on the anatomic location and where the auscultation is actually being done from. And depending on the intensity, you can grade it on a scale of 0 to 4, though this has some debatable clinical significance, but 0 if there's nothing, 1 if it's barely appreciated or perceived, 2 if there are diminished sounds, 3 if it's normal, 4 if it's louder than normal. And remember that in the right context, your intensity of your vesicular sounds can indicate pathology. For example, if you have a greater intensity of the breath sounds, it means that there's more ventilation that is happening, in contrast to you having quieter breath sounds where there's decreased ventilation. We see this in example, patients that have asthma. When they have a silent chest, you're not going to be able to hear anything in their chest. It doesn't mean that the patient is improving. It means that air is not actually entering into their chest. Then if they have fluids or air or other matter that is in the pleural space, it may sometimes decrease the intensity of these sounds that you hear, because they are going to be muffled out, because the fluid that is in between the lungs and the chest wall is going to interrupt how well you hear those sounds. Sometimes you may get this asymmetric intensity of sounds where they are louder on one side and they are not so loud on the other side. For example, in intubation, remember, if you push the endotracheal tube too far, you may end up in the right main bronchus as opposed to it ending up in the trachea. So this will give you this asymmetrical breath sounds, and you can actually pull back on the endotracheal tube so that you avoid an endobronchial placement of the tube. So we'll begin with the first sound, which is a tracheal sound. So each of these abnormal sounds, I've added a clip that will help you actually appreciate it. So the first one is, of course, the tracheal breath sound. So these ones are going to be heard best over the trachea. They are very loud. They have the same duration in expiration and expiration as equally present. And this is what they sound like. So this was a tracheal sound that was played from an interscapular region. So have a listen to it. Have a listen to it. Okay, I hope you heard that quite well. So if you did not, just rewind the video and actually play it back. So that's what a tracheal breath sounds like. Very loud. There's equal sound intensity in expiration and inspiration. The next sound is a bronchial breath sounds. This one's usually arising from the tracheal bronchial T. So you can actually hear them best over the manubrium of the sternum. They can also be heard over the trachea. They can also be heard at the right apex of the lung. So you're going to get this loud, harsh, high-pitched bronchial breath sound. These ones are heard predominantly best on expiration. So it means that the duration of expiration is going to be much longer than the duration of inspiration. And you can think of it like this. The air The lungs that are supposed to be filled with air have now typically collapsed or have been filled with tissue or have been filled with fluid, and such that you create this sound which is much louder because that solid tissue tends to conduct sound much better than the air that was filling in that particular area. So you may get these abnormal sounds in other areas of the lungs, showing that there's a pulmonary consolidation or there's a pulmonary collapse. And sometimes this is one sound which is quite tricky, because if you hear it from the right apical area or you hear it from the trachea, the sternal region, you may be confused and think that this is abnormal, but it's normal. If you hear it any other place aside from these areas that I've mentioned, the trachea and the right apex of the lung, it's going to be considered as abnormal. So you must have a bit of some discretion when listening to it. So here's what a bronchial breath sounds like. This was a pneumonia of the left lower lobe. Okay, so that one wasn't so loud. Okay, so I'm sure you can even appreciate the sound. You can even hear the heartbeat, so that the sound is not so loud, because I think it's being muffled out by something that's happening in this particular patient. The next is a vesicular breath sound. So these ones are normally going to be arising from the lung parenchyma. They're heard in most of the areas of the lungs. These are the ones that you should actually be able to pick up, because most of the normal patients that have a normal lung sound are pretty much going to sound like this. So they're going to have this soft, low-pitched sound. It's heard best during inspiration, but remember that the expiratory sound is shorter than the inspiratory sound. Most of these are appreciated well best in the posterior lung basis, and this is what they sound like. Here's one normal vesicular breath sound. Then sometimes you may get a bronchoversicular sound, which is commonly heard over the upper third of the anterior chest. It can best be appreciated from the first and second intercostal space, posteriorly between the scapulae. So here again, the duration of expiration is the same as the duration of inspiration, and it has an intermediate intensity and pitch. Unfortunately, I didn't manage to find a sound for you for this particular one, so you can just simply do a quick Google search. You should be able to find what it sounds like. Then now we'll move. Remember, we're going to be discussing these abnormal sounds under 3 headings. So you have the breath, the normal sound, normal lung sounds, then you have the adventitious sounds, and then you also have vocal resonance. So I've tackled what the normal sounds like. Now, what does the abnormal sound like? So remember that these are going to be heard, and generally they're going to be things like crackles, which are also referred to as crepitations. They're also referred to as rails. You can hear rhonchi, you can hear wheezes, you can hear stridor. The other things that we'll discuss include the rubs, the inspiratory gasps, Hammond's sign, which is the mediastinal crunch. We'll also talk about grunting. So there are many different terms that are going to be allocated to these different adventitious sounds, and they're quite numerous for us to actually even cover in one particular video. So the terms generally have now been thought of as redundant, or sometimes they are subcategories of one of the things that we have talked about already above. Or for instance, the crackles or rails, you can use the same term to talk about the same findings, or even sometimes crepitation. So it depends on where you are, the clinicians, which one they prefer to use, whether they prefer to talk about it and say crackles or rails or crepitations. So generally, these adventitious sounds are abnormal. You're not supposed to see them. You're not supposed to hear them, rather. So they are going to indicate that there is some sort of pathology. So you should tie this clinically to your clinical context, your history, and other physical examination. So, for example, if you get a patient that has crackles or rales, this is just simply because of the snapping opening of the airways. So we often see it in conditions like interstitial lung diseases, pulmonary edema that is arising from heart failure, even infections like pneumonias. Then the high-pitched sounds, the high-pitched crackles, these ones are going to be, for example, representing the lung interstitial disease, while as the low-pitched crackles are going to be pointing you towards chronic lung obstruction, the chronic obstructive lung disease. Alternatively, also, for example, with wheezing, you have this air that is moving through a tube. Remember that once air moves through a tube, it creates a certain sound. If that tube has been narrowed because of maybe inflammation of the wall, because of mucus in the lumen, it will create a specific musical-like sound, which is known as a wheeze. Sometimes we refer to it as a rhonchi. It's often seen in conditions like asthma, seen in conditions like chronic obstructive lung diseases, even some focal masses like tumors. And I will keep emphasizing this. If you don't have any clinical context, the sounds are going to be quite fairly nonspecific because they could represent a myriad of a lot of things. So the duration, rather than the pitch of a wheeze, for example, throughout respiratory cycle is going to be most predictive of the pathology. So you must tie this to your clinical context. So how do we differentiate between these different adventitious sounds? So one thing you must ask yourself is whether this is a continuous thing or it's an intermittent thing, whether it's a high-pitched thing, a medium-pitched or low-pitched thing. In terms of it being continuous, for example, the rhonchi and the wheeze can be continuous, while sometimes the crackles cannot be continuous, and then sometimes the crackles can be counted as a discrete acoustic event when it's interrupted, or sometimes the wheeze and the rhonchi can be inseparable. So they'll be constant, like a whirling of a fan. So in terms of the pitch, remember that the wheeze and fine crackles are high pitched, whereas the rhonchi and the coarse crepitations are low pitched. That's one way in which you can distinguish between these different adventitious sounds. So we'll begin with the most easiest to pick up. I often like to describe this to my students as imagine someone walking on dry leaves. Or if you have Velcro, those hooks and loop fasteners, if you pull it apart and you open it apart, it sort of sounds like that, but it's easier to imagine someone walking on leaves. So generally, remember that your crackles or your rales or your crepitations are going to be due to this opening of the small airways. And because the airways are opening, it's often going to be attributed or heard best during inspiration. So it's this discontinuous, interrupted, or explosive sound. They might sound like rattling, bubbling, or clicking. And sometimes these crackles may be continuous, but in most of the times they are discontinuous. So they may be either fine or high-pitched or coarse or low-pitched. So the short, high-pitched sounds or fine crackles, you may see them in certain conditions. The coarse crepitations can be seen, which are low-pitched and last longer, can be seen in other conditions. For example, with fine crepitations, you may see them in pulmonary edema, while as in coarse crepitations, you may get them in pneumonias, for example. So generally, distinguishing between these is going to come largely from the size of the airway that is opening. For example, the larger airways will have a deeper pitched and coarser crepitations as compared to the smaller airways. So you can also describe these as moist, dry, fine, or coarse. And they are seen in conditions like pneumonia, in conditions like pulmonary edema, in TB, bronchitis, and even heart failure. So here is an audio of fine crepitations. Have a listen. So I'll play that once more. Here's one with fine crepitations. And here's one with coarse crepitations. Notice the difference. The fine crepitations have a high pitch and the coarse crepitations have a low pitch. So I'll play the coarse crepitations again. So the next is the rhonchi and whiz. Remember that these ones represent a similar pathology, and you can only differentiate between them based on the pitch. So generally, remember, if you have a tube and you're pushing air into it, it's going to create a certain sound. Once this tube becomes narrowed, the fluttering of these narrowed airways is what creates this abnormal sound. Remember, in terms of a wheeze, you can hear it without a stethoscope, but rhonchi, you need a stethoscope to hear it. The wheeze is usually quite high-pitched, the rhonchi is usually low-pitched, but both of these sounds are usually continuous. They are going to be heard burst during expiration. They can be heard on both inspiration and expiration, but they never are heard on inspiration alone. So interestingly enough, the physicians often agree on auscultation of wheeze, but far less other findings such as crackles. So in terms of the wheeze, you get these musical sounds that are going to be created. As you get this air that is flowing out, remember that expiration is a passive process. So as the airways are having that elastic recoil, some of them collapse, some of them are trapped with mucus, and some of them are inflamed, especially the small constricted small airways, such as the bronchial. So as air is moving through these, it's going to create this musical sound, which is a continuous high-pitched hissing sound, which is known as a whiz. You can also refer to it as a sibilant rhoncus. So it's commonly heard during expiration, like I said, and you can sometimes hear it during inspiration and expiration, especially in asthma. It can also be seen in other conditions like COPDs and foreign body aspiration. This is what a wheeze sounds like. Then next we have a rhonchi. So remember that here, these ones are going to be also continuous. They are low-pitched sounds. They're going to be also heard best on expiration. They are a bit much more coarse, and they're going to be usually pointing towards constriction of the larger airways as opposed to the wheezing, which is the smaller airways. So it can actually even include the tracheobronchial passages. So they'll sound like these snoring or gurgling sounds, or sometimes you refer to this as a sonorous rhoncus. So this is what they sound like. Then we have stridor, which is this high-pitched continuous sound. Often it's going to be indicating upper airway obstruction. Remember that wheezing and rhonchi represent lower airway obstruction, while a stridor represents upper airway obstruction. Rhonchi and wheeze are best heard during the expiration, while a stridor is best heard during inspiration. So in terms of stridor, you also get this wheezing or squeaking sound, and you can distinguish it from other sounds based on its intensity in the neck more than in the chest because it's upper airway, the timing, it being inspiratory, and the pitch because it's quite high-pitched. Remember, wheezing, just like wheezing, stridor is also going to be showing you some sort of airway narrowing in the upper airways. So it could be due to epiglottitis, foreign body aspiration, laryngeal edema, and even in croup. This is what it sounds like. Then we move on. We now look at pleural rubs. So here you get this sound which is outside the chest. So it sounds like two balloons rubbing against each other. This discontinuous low-pitched grating sound, that's going to be because of the pleura that are rubbing on one another because they are inflamed. So usually it's louder than the other lung sounds because it's much closer to the chest wall where you're listening with your stethoscope. It can be heard both on inspiration and expiration at mirrored points of the cycle, and generally it's often quite confused for crackles, but it's distinguished because the rubs are biphasic. They are going to be localized and often are going to be overlying a point of the chest wall where there's pain. And often we see these in inflammation of the pleura, we see these in tumors. So I added two different types of sounds, but both of them are pleural rubs, but they sound a bit different, so that's why I added them here. Don't confuse this with crepitations. Then the second sound. So lastly, you also have other sounds like inspiratory gasps. Generally, this is going to be a continuous high inspiratory whoop that is heard during pertussis, whooping cough. I think I did a video on whooping cough. I will leave tagged at the end of this particular video that you can check out. I play the sound in that particular video. Then you may sometimes have hum and sign or mediastinal crunch. You get this discontinuous crunching or rasping. Sounds like you're opening a packet of chips. That's often heard in pneumomediastinum, even pneumopericardium. You may also get grunting, which is this continuous low-pitched sound that is going to be heard on expiration. It sounds like snoring. It's seen commonly in the smaller babies, so it's going to be seen in surfactant deficiency, pneumonias, even cardiac abnormalities. Then last thing that I want us to talk about, I didn't add any sounds to this, unfortunately, so I just want us to have a discussion. So remember that the lungs are going to act sort of like a filter. So they're going to be a low-pass filter such that they will allow these low-frequency sounds to move through easily, while as the high-frequency sounds cannot move through easily, such that if there's a pathology affecting the lungs, these dynamics are going to change. So if the lung has a sort of a problem, it means the higher frequencies will be transmitted more efficiently than the lower frequencies. So this is going to be occurring where, for example, you get these alveoli that were initially filled with air, then they're going to now be filled with material such as fluid or tissues. So generally, we can use this phenomenon to actually tell, based on our physical examination, what is known as vocal resonance. So generally, it's going to include things like bronchophony, egophony, and whispered pectriloquy. So in terms of these tests, remember you're going to place your stethoscope over your patient's chest and you ask them to say certain things. You ask them to speak 111, 99, various other different types of words. So generally, you as your clinician, you're going to hear an unintelligible, distant, or even muffled sound. So in terms of bronchophony, the voice of the patient is going to appear closer and louder because it's being transmitted. You have this tissue which is transmitting this sound much better than air, which was normally supposed to be there. Egophony sometimes occurs where you get this distortion of the vowel sounds and it makes it more easy, more like as if they're speaking from their nose, so a nasal type of quality. So a sound that is like of a hard E will be heard like an A and is referred to as an EA change. Then you may sometimes have whispered pectriloquy, which is simply going to be this clear and intelligible sound when a patient whispers. It's usually unclear and unintelligible. So generally, the ease of transmission of certain frequencies is going to change with pathologies. Like I said, what was normally filled with air, now, if, for example, if it's filled with tissue and fluid in lobar pneumonia, it will change this dynamic. So generally, fluid is going to be transmitting this sound better than air, so vocal resonance is going to be increased. So you're going to have things like bronchophony, egophony, even whispered pectriloquy, which are going to be present. In contrast to this, if you have fluid surrounding around these lungs, this transmission is going to be worse. So the lower frequencies are going to be transmitted less, but the higher frequencies will be transmitted better. And the sounds may even be muffled up or sound a bit distant. So the findings can actually be dynamic and inconsistent. So you may have decrease in vocal resonance sometimes, which can occur if enough fluid builds up between the stethoscope and the lungs in terms of a pleural effusion. Then when you're assessing the vocal resonance, remember you should compare the sounds at equal sides from the left side to the right side at the different locations throughout the lungs. So even in your healthy lungs, there will be some sort of distorted transmitted sounds, but a unilateral change often is going to be pointing you towards a pathology that is there in this particular lung. So remember, to actually pick up and learn these sounds, you must first learn what the normal is. Once you learn what the normal is, it'll be very easy for you to actually pick up what the abnormal is. So the normal thing to do right now is to go auscultate as many normal chests as you can, pick up what the normal sound sounds like. And then once you encounter an abnormal sound, you'll be able now to learn what these abnormal sounds are and what they actually entail when you link it to your clinical context or your clinical history. I really hope you enjoyed this video on lung sounds. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.